The next speaker is another anaesthetic colleague of mine from Liverpool called Dr. Seema Agarwal. And Seema's going to talk about deep hypothermic circulatory arrest and left heart bypass and some of the coagulation issues that they present to us.
Thank you, Mike. As Mike said, I'm going to talk about these two different types of bypass and the coagulation issues. I'll show you a bit of evidence that I found from my own reading of the literature and some data from Liverpool. Those are my disclosures. So this is the blood usage at Liverpool over the past year, so 2013 to 14, for our aortic programme. And you can see that on average, our aortic patients are using 4 units of red cells, 4 units of FFP, 2 platelets and 2 cryo. If you divide that into the type of surgery they're having, you can see that the arch patients are getting fairly much the average amount of blood usage. The others, which are things like roots, are just getting a little bit of blood. But you can see that our descendings and thoracoabdominals are receiving a huge amount of blood, 11 units of red cells on average, 4 FFP, 3 platelets and 2 cryo. This isn't something that's in any way unique to Liverpool. This is from a study of transfusion in aortic surgery. The investigators were looking to see whether a ROTEM-based algorithm would reduce transfusion, which it did. But what I want you to take from this slide is really that their usage is fairly similar to our own. They're using 6 to 9 units of red cells, 4 units of FFP, 4 units of platelets, and they're using fibrinogen concentrate of about 2 to 4 grams per patient. So what is it, apart from the vascular nature of these operations, that means these patients require so much blood and so many products? The problems in the coagulation system with deep hypothermic circulatory arrest are well known, and they're essentially like being on bypass, but in the extreme. And so you have extreme hypothermia with a slowing down of the enzyme kinetics and impaired platelet function. These patients quite often have abnormal endothelial expression of TPA, and so they have a hyperfibrinolytic state. And they also have the extracorporeal circuit, and so they have thrombin deposition on bypass despite the use of heparin. You have activation of coagulation and a decrease in platelet number and platelet function. And clearly these are going to lead to an increase in transfusion and its risks. Left heart bypass is a slightly different thing. If we look at these patients, it's been found preoperatively that they have a baseline activation of coagulation and thrombolysis, so that they have, before the operation even starts, they have raised antithrombin, raised fibrinogen degradation products, and raised antithrombin-thrombin complexes, all of which indicates this activation of the coagulation pathways. At this point, however, they have a normal fibrinogen level, which makes you think it's a very low-grade thing that's being compensated for very well by the body. Perioperatively, clearly, they have a major blood loss, and they get a dilutional coagulopathy. There are also changes to do with the clamping of the descending thoracic aorta, which I'll come on to in a second. And it's well known that all these things will increase transfusion. The transfusion in these patients in particular is associated with death. So if we look at the changes with clamping, this is all data from a very old study by Cambria's group in Boston, where they looked at the changes in thoracoabdominal aortic aneurysm compared to abdominal aortic aneurysm, where they'd noticed that the thoracos had a far greater coagulopathy. And they wondered whether this was due to the left heart bypass circuit and the heparin in that, or whether there was something particular about these patients that caused them to have a greater coagulopathy. What they found was that 30 minutes after clamping the aorta in the chest, so above the diaphragm, there was a significant reduction in all factor activity, a significant reduction in fibrinogen, and an elevation in D-dimers, all indicating a fibrinolytic state. They postulated this was due to intestinal ischemia precipitating DIC. They found raised TPA activity and raised fibrinogen degradation products. This is some data from a dog model, which the poor dogs were put to sleep, opened up, and they just had their supraceliac aorta clamped. Nothing else happened to them. And it was found that very soon after clamping the supraceliac aorta, the platelet level fell and continued to fall every 30 minutes. They checked the levels from 100% of baseline down to about 25% of baseline after 90 minutes of clamping. And the fibrinogens also fell. So 30 minutes after clamping of the aorta, it had fallen to almost 50% of its baseline level. This isn't something that's unique to dogs. In people, we also find that just by clamping the aorta, we drop our fibrinogen level and we drop our platelet level. Also in left heart bypass, after the repair, there's persistent activation of coagulation, probably related to the atherosclerotic disease these patients have. So you can see with the two different types of bypass, you have quite different problems. With deep hypothermic circulatory arrest, it's all to do with the actual bypass, the cold, the hemodilution. With left heart bypass, there's more preoperative activation of coagulation. There are all these changes to do with clamping and a significant reduction in fibrinogen. Also worth mentioning changes in platelet function. This is some data from our own work at the moment. And we're using the multiplate to look at the trap area under the curve, which doesn't really change in patients not having normal cardiopulmonary bypass. So the blue line is deep hypothermic circulatory arrest, and you can see that platelet function falls very rapidly when you start deep hypothermic circulatory arrest. It slowly gets better towards the end of the operation and almost rebounds at 24 hours. Despite all the problems with the clamping and the ischemia with left heart bypass, platelet function is actually fairly well maintained. And you can assume that's due to the fact that the left heart bypass circuit hasn't got an oxygenator in it, so you don't get that platelet consumption. We use less heparin, and so there's less activation of coagulation, and there's only very mild hypothermia at most. So given the fact that we have all those problems with coagulation, what are we going to do about it? These are historically the things we've done. We've used cell salvage, we use antifibrolytics, and we do use quite a lot of oprotenin. We use preemptive transfusion, and we base it all on point-of-care testing. But given the fact that we do all of those things and we still have very high transfusion rates, is there anything else that we can do? Over the past few years, there's been a lot of interest in using fibrinogen concentrate in aortic surgery. So if we take a look, first of all, at some physiology, the physiology behind massive blood loss has been very well studied. This is studied not from aortic surgery, but when patients were bled circulating blood volumes, and they looked to see the changes in platelet and fibrinogen levels. So if you look at the top two, you can see with a circulating blood volume, losing a circulating blood volume, your platelet count falls, your fibrinogen level falls. They then looked at these levels as compared to what a theoretical washout curve would give you, so which is the two graphs at the bottom. You can see that the fibrinogen level on the right-hand side of the screen follows the washout level very as it should do. The platelet level seems to fall less slowly than one would expect. What they then did was to put in where they thought the critical level of fibrinogen and the critical level of platelets would be. So a fibrinogen level of 1 gram, a platelet level of 50. And what they found was that the fibrinogen level fell much more rapidly than the platelet level. Fibrinogen, I'm sure you all know, but fibrinogen is a large glycoprotein. It has two roles in coagulation. So it circulates as a soluble plasma component, and it's responsible for platelet adhesion with the glycoprotein 2B3 receptor. So when the platelets are trying to form the primary hemostatic plug, fibrinogen acts as a ligand. So it's necessary for that first step in coagulation. Fibrinogen is also cleaved from thrombin into fibrin. It becomes insoluble and it forms a meshwork which is useful for cell propagation. This is an analysis of our own data in aortic surgery, which very clearly shows that as your fibrinogen level falls below about 2.5 grams, your red cell usage increases almost exponentially. So it's clear that actually finding some way of giving fibrinogen to these patients is going to help us with blood loss. In 2009, Ra Meyer and his colleagues working out of Hanover presented the results of a very small study looking at the use of fibrinogen concentrate. So in this study, there were 12 retrospective controls and 6 prospective patients. They dosed fibrinogen concentrate using a point-of-care device, the ROTEM, and they aimed for fibrinogen concentration in the body of about 3.6 grams per litre. The primary endpoint in the study was all transfusion in the first 24 hours, and you can see that the fibrinogen concentrate group received far fewer red cells, FFP, and platelets, going down from 4 red cells to 1, from 9 units of FFP down to 1, from 3 to virtually no platelets. More impressively, out of the 6 that received fibrinogen concentrate, 4 patients required no transfusion whatsoever, this in major thoracoabdominal aortic surgery. They also reported significantly lower drain volumes and a decreased length of stay on the intensive care unit. They didn't report much about safety, but they did look at the fibrinogen levels after the operation. As you might expect, the fibrinogen level immediately post-op was much higher in the fibrinogen concentrate group compared to the placebo group. This had pretty much disappeared on the first post-operative day. And you can imagine this is because fibrinogen is an acute phase protein. It rises in everybody. And the fibrinogen concentrate that's been given has turned into this insoluble fibrin and formed a meshwork. So this is a very promising study, but it had tiny numbers, 6 patients who'd actually received fibrinogen concentrate. In 2013, the same group published further work in this area, this time a placebo-controlled study. They used the same methods as before, using the FibTem to guide their fibrinogen concentrate, giving fibrinogen concentrate to get to a level of about 3.6 grams per litre. In this trial, they divided the patients into placebo and into fibrinogen concentrate groups. Again, the primary endpoint was blood components in the first 24 hours after administration of the IMP. And you can see that, again, they had very highly significant results. Reduction of transfusion in red cells, FFP, and platelets. And again, you can see that there were 13 out of the 29 patients who received fibrinogen concentrate who required no further transfusion whatsoever. They did look at some adverse events this time. They found that there was 1 myocardial infarction in the fibrinogen concentrate group, 1 cerebral infarction in the placebo group. So again, another promising study building on their previous work, but still very small numbers of patients that have been treated. And what they had done is excluded those at the highest risk of bleeding and excluded those with the highest thrombotic risk. So then the REPLACE study was started in 2011-2012. It was sponsored by CSL Behring, who are the manufacturers of fibrinogen concentrate, and they aimed to assess the safety and efficacy of fibrinogen concentrate in aortic surgery. So this was an international phase 3 randomized controlled trial. It recruited 284 patients to placebo, 284 patients to the fibrinogen concentrate group. And the primary endpoint was, again, the total number of blood products transfused in the first 24 hours. So the study patients underwent surgery. They came off bypass. They were given protamine. The surgeons did as much hemostasis as they could. At that point, a 5-minute bleeding mass was performed. So all suction was taken out of the chest. The chest was packed with swabs. They were left in for exactly 5 minutes and then weighed. If the weight of the blood was between 60 and 250 grams, the patient triggered the protocol and was allowed to have either fibrinogen concentrate or placebo. After giving the fibrinogen concentrate or placebo, they went through further rounds of this 5-minute bleeding mass, getting platelets or FFP as needed. This completed in the middle of last year. The full results from the study aren't available, but what I can tell you is they didn't achieve their primary endpoint, and so there was no difference in transfusion between the placebo group and the fibrinogen concentrate group. There were, however, no safety concerns with the use of fibrinogen concentrate, and it was very well tolerated. There were lots of unusual things that went on in this study, and it would be interesting to see the full results when they're available. Personally, I think fibrinogen concentrate is going to have a role in aortic surgery, especially if you remember this, that when the fibrinogen level falls below 2.5, your blood cell usage just soars. Given the fact we can't use fibrinogen concentrate yet, is there anything else we can use? We can use factor 7, and there's quite a lot of evidence to show that factor 7 is very good as a rescue treatment. And you can see from the top graph that as you give factor 7, your blood loss pretty much disappears, compared to that kind of slowly tailing off that you get without factor 7. There's been a little bit of work using factor 13. Factor 13 is the terminal enzyme in the coagulation cascade, and it's needed to form a very strong fibrin clot. Cardiac surgery is known to decrease your factor 13 levels, and that has been associated with bleeding in cardiac surgery. So there's some preliminary trials undertaken which looked at the difference between placebo, low-dose factor 13, and high-dose factor 13. There's another randomized controlled trial. Unfortunately, yet again, they showed no difference in transfusion whatsoever. And so what are we going to do about these patients? I'll bring you back to the first slide. Cell salvage, antifibrinolytics, using O-protein, I think, preemptive transfusion, point-of-care testing, and then taking a few things from that whole patient blood management spectrum of trying to optimize preoperative hemoglobin using fibrinogen supplementation. I'll leave it there. I'll take some questions if there are any.
Thank you. You had 18 seconds left.
Thanks. Thank you very much. Is there any question?
Seema, what do you think about the use of A-proteinin in these patients?
What do I think about these A-protein? Personally, given the opportunity, I would use it in all of them. I think it reduces your blood loss significantly.
Yeah, we used to have a lower blood loss when we used it routinely.
And I think that there's some data from a Bristol study which shows that when they lost a protein, their blood loss and mortality increased by about twofold. So I think it's definitely worthwhile in these patients.
Please.
You mentioned that you preoperatively transfuse patients that are identified as anemia. If they're identified early, have you got a pathway for dealing with preoperative anemia in your place?
We have got a pathway. Unfortunately, we don't have funding for our pathway for preoperative anemia. So we have developed a way of identifying the patients, giving them IV iron and EPO. As all things in the NHS, it's falling down on the lack of cash.
There's been some recent work looking at intraoperative platelet pheresis in this population, extracting those platelets before they're activated and destroyed. Do you have any thoughts on that or aware of any of that data?
I am aware of some of that data. It's not something that we do at Liverpool, but it does seem to have, it seems to be very promising.
If I could make a point on that, I mean, I think it is probably at its best with a straightforward procedure where there is a predictable amount of bleeding, because I think you're sort of trying to do preoperative platelet pheresis. I think the difference will be small, and if you're doing it in cases where the bleeding is unpredictable but can be large, it would be very difficult to ever prove that it was of benefit or to discern a benefit if you used it, and that's one of the reasons we didn't progress with it. I mean, do you have more knowledge on that?
Yep. Thank you.
Our management of the blood product and transfusions is transformed following this Afghanistan war and everything else with the trauma and major massive transfusion. And in our practices in thoracoabdominal and all the other major operations, still not completely changed. Do you think we should be using TEC and Roten more frequently throughout the procedure to correct it, like these people did in the war zone? like in a thoracoabdominal theater, it's like a war zone, isn't it? And then afterwards, post surgery, first night volume replacement, and then transfusion management. Do you think we need to be guided by Rotem and TEC?
I think we should always be guided by point of care testing. I think the problem has been that, particularly in our institution, is been with training and with quality, and that's a problem that you find throughout most centres in terms of quality control with the TEG. But I do think that we should be using the TEG, and particularly the fibrinogen TEG, to help us guide what we're doing and to stop us giving. I mean, I think if you remember the data, we're giving all this FFP. I'm not entirely sure it's all that necessary. I think probably we should be trying to focus on what we know are the problems. So we know that we drop our platelets, we know that we drop fibrinogen, and we should be targeting our therapy more towards that.
Listen more.